They're really good. They're just not strong enough.
Okie dokie. So here's our little bit of housekeeping. So there was some craziness in the assignment dates, and I apologize to you. When I was setting up this course, it was copied over from last term, and I only corrected the dates through probably week 4 because I was dividing up some of the assignments. So if you've already submitted some things like the antihypertensive, you don't have to submit it again, but it's actually not due for a couple of weeks. So 5A is due today, 5B is due next week. And then the numbers on the assignments won't match any up anymore because assignment number, what is it? The study guides for 6 are due in week 7, and the study guides for 7 are due in week 8. Just, I fixed the dates. They should all show up. Everything should be copacetic. So 5A is chapters 18 and 19, the adrenergic drugs. 5B is 20 and 21, the cholinergic drugs. So that's that. There's case study. The sleep is due this week on Friday. It's within Canvas, so have fun with that. Some people still haven't, a couple people haven't done quiz number 2, which was due on Sunday. So you have 7 days from Sunday to complete it for 10% off. Quiz number 3 covers chapters 18 through 21. So those are all the autonomic nervous system. So they get their very own quiz. I'm moving back the due date. So it's going to be actually be due the morning of the exam because it's all that content is on the exam. So a week from Thursday is our next exam. Shocker. So that's, the exam is 10 through 21, but the quiz is 18 through 21.
When are you gonna post quiz 3?
Post what?
Quiz 3?
Thursday probably, because something happened and the people can't fix it, so I have to write it all over again.
Oh no.
No, you wouldn't even believe the crap. You think your lives are hard? Oh, well, what are you gonna do? And then, let's see. I think that's it. Any questions about anything that I forgot or, yeah?
The 5B,
5B.
it didn't have,
It does now.
okay, but I put 5A and 5B together.
Okay, send me an email so that I remember to give you credit for both. Or you can just upload the same document into 5B. It'll be
Okay.
easy. Yeah, if you put everything into 5A and now there's a 5B, put the same 18 through 21 in 5B. Just, I'll look at it and say, oh, yeah. But it's not, 5B is not due till Monday. So the plan, the overview is, let's finish, what, 15, what are we on? Parkinson's?
Halfway through.
I believe, were we still on Parkinson's? Okay, and then we do psychotherapeutics. And if we can get through that, we'll play a game to review all of the things in there. Substance use disorder is the last item in that cluster. I'm pretty sure we won't get to it today. If we do, more power to us. If we don't, we'll start with it on Thursday. And then I suggest if you are not fluent in the autonomic nervous system, which I know you all are, you all speak neurotransmitters, and you know all the receptors and all of that. If you're not familiar, it's good to come to class because we do start with a review of that. It helps you understand how the drugs fit in. So that will be on Thursday. We'll finish up. So we'll probably do adrenergic on Thursday, cholinergic on Monday, exam the following Thursday on 10 through 21. It's a lot of stuff. The blueprint is posted. It tells you how many questions are in each topic. I've already created the exam, but I've already forgotten what's on it, so I couldn't even tell you. But let's get started on, let's see. We'll look at this one. We were somewhere in there. Talked about on, off, bromocriptine, the cont inhibitors and the non-depressive MAOI. Let's see, dopamine modulator, anticholinergic therapy. Let's look at anticholinergics again. This will be clearer when we talk about anticholinergics in the parasympathetic nervous system. But for now, I would put like a little sticky note to come back and review this once we've discussed kind of what happens in that system and why we either promote or block acetylcholine. But acetylcholine is the primary neurotransmitter in the peripheral nervous system. And so some people with Parkinson's have excessive acetylcholine, and so they have excessive cholinergic activity. And so sometimes we give them an anticholinergic. The trouble with anticholinergics is that they have a lot of unwanted side effects. They're very drying. They can cause urinary retention. They slow your bowels. They give you dry mouth. So lots of issues with that. But like I say, put a little bookmark that you will review this after we go through the anticholinergics, and then you will kind of connect it with benztropine used for the treatment as an anticholinergic. You'll also bookmark this when we talk about the antipsychotics, because there are potential adverse effects from antipsychotics called extrapyramidal symptoms, which we'll go over. And so this anticholinergic can be used for excessive acetylcholine in Parkinson's and for extrapyramidal symptoms from antipsychotic drugs. We will talk about those in a minute. The precautions of this is that we have to tell them to not get overheated. So, no saunas, don't go out and sunbathe. We have all these Parkinson's people out sunbathing. I don't know. But again, lots of adverse effects. And because it's an anticholinergic, we never know if someone is going to be sensitive to it or be taking other drugs that have anticholinergic activity. There is something called anticholinergic syndrome, which is just excessive blockage of acetylcholine, where there's agitation and delirium, and sometimes it's like people have visual hallucinations. Sounds like a lot of fun to me, but generally, obviously, anything messing with acetylcholine and all of our, we just say avoid alcohol with just about everything. Just like grapefruit juice, you just tell people no grapefruit juice and no alcohol. And then we went over this one, which is the drug most likely to cause postural hypotension. So this doesn't list every drug that has postural hypotension, but there is a category of drug that was known to. And so we want to kind of review that Sinemet, which is carbidopa-levodopa, the amantadine, the ropinirole, brand name Requip, all have the potential to cause that drop in blood pressure with going from lying to sitting or sitting to standing. All right, I think this is about where we were. What do we provide a patient? No, we went over this, but really fast. We're teaching a patient about they're getting this perhaps benztropine anticholinergic drug. And we were saying to ourselves, okay, this is an anticholinergic, so we'll review like what's our patient teaching, what are the side effects, and So we go through and what should we tell them? Well, we tell them, we try not to take them at the same time as other Parkinson's meds. This particular anticholinergics for Parkinson's, we recommend them be given at bedtime. That's a specific time of day that you should know for a specific drug. We never tell people who have a dry mouth, unless they're on a fluid restriction, there's no reason to tell someone with a dry mouth that they have to restrict their fluid. Dry mouth is an adverse effect of an anticholinergic. People really, really suffer. So, you know, sometimes we tell them to drink more fluids, but also they're oftentimes older people in their 60s or 70s, and they don't want to drink a lot of fluid because they have to go to the bathroom a lot. So all of the things that you learn in nursing school that are substitutes for drinking, chew gum, suck on a lollipop, have a pacifier, I don't know. And then the time to onset. The time till we see any benefit of the medicine is weeks. It's not hours, it's not days, it's really weeks. Black box warnings, all right. Well, we did talk about this one. So this is tolcapone is famous for causing severe liver injury. It's a rare side effect, but they do sometimes ask about this particular drug and its impact on liver. So that's what labs would you be monitoring then for a patient who's on this medicine if we know that they cause severe liver injury? What labs do you monitor? Liver function test, right? LFTs. All right, bun and creatinine are renal tests. Good guess. Appreciate any guesses. There's a panel called liver function test, which is AST, ALT. They have different terms now. Bilirubin, direct and indirect. There are people who are on plain levodopa. Not a lot, but there are a few people. So if you have a patient who's on plain levodopa and they're switching them to carbidopa levodopa, well, what do we know is the role of carbidopa?
Transport.
Right, it's a helper. It helps transport. So if you suddenly give carbidopa and they're already on a dose of levodopa and you're giving Cinnamon that has levodopa, they're going to be overdosed on levodopa, right? This carbidopa is not only going to help the levodopa get in the brain in the Cinnamon, but the plain levodopa as well. So they're going to get slammed with levodopa. So we have to have this sort of a bit of a 12-hour washout period. And that's sort of an unusual thing. Chapter 15 case study number. Let's look at this one. Mrs. J has been coming to your clinic to monitor her narrow angled glaucoma. Lately, she has some tremor and postural instability. When she also experiences increased rigidity, she undergoes some diagnostic tests to rule out suspicion of other disorders. She gets diagnosed with Parkinson's, so PD is Parkinson's disease. You're thinking, well, I think they're going to probably start her on bromocriptine, but that wasn't started. And so why did we think that they may have started her on bromocriptine? If you remember, I'll go back in your slides to the pharmacology on bromocriptine. And so instead of bromocriptine, she was given another drug that was not carbidopa levodopa. The second question is, why do you think the provider chose this drug when you need to teach her regarding the disease and goals of medication therapy, what you need to teach regarding taking the prescribed drug? So here's all the answers. So amantadine is, the issue here is they gave you this one little key of a drug contraindication, narrow angle glaucoma. So some drugs are contraindicated in narrow angle glaucoma. We knew that amantadine and bromocriptine were not. If they didn't start her on bromocriptine, it would be possible that they would start her on amantadine. Why is it advantageous? Because we know that it's most effective in the earliest stages of Parkinson's. So we have active dopamine release and receptors. It's a good time to use the drug, because if we wait till later stages when all the receptors are destroyed, it doesn't do a lot of good. So as the disease progresses, as we said, this amantadine becomes ineffective, and they could switch her to bromocriptine or ropinirole. What do we teach people? This is the same thing as in seizure therapy, right? We teach that the goals of therapy are to maximize the daily function, minimize the adverse effects, if possible, to delay disease progression, disease symptom progression. The disease will progress. We're trying to maximize the therapeutic benefit of when we time the starting of levodopa, because what's the problem with levodopa? How long is it typically therapeutic for? 5 to 10 years, right? It's only good for about 5 to 10 years, and then it loses its effectiveness. So timing it just right is key. So know what your goals of teaching to your patient are, what we're trying to accomplish, what do we know about the disease, unfortunately, and what we're trying to balance. Benefits of treatment, unfortunate adverse effects. And then we also have to teach them that amantadine is only good for 6 to 12 months. So know their time frames. Amantadine is only good in the early stages of the disease. It's only good for 6 to 12 months. Sinemet, carbidopa, levodopa. It's mostly good in early to mid of the disease. Only lasts for 5 to 10 years. All right, that was that. That was a lot of really fast finishing of that. Go back and start writing down, okay, here's what we're looking at. We're looking at Parkinson's disease. What are the categories of meds that we can use? You kind of list out the categories. Then you kind of put the drugs, and you put what are the contraindications to particular drugs. You kind of write all of the key things need to know, like, oh, we don't use this in narrow angle glaucoma, or, oh, we only use this in early phases of the disease. Kind of set it up that way so that when you are referring back, you can kind of figure where they fit in that little umbrella of medications, theoretically. That's how I study, God knows. Let's look at, that was Parkinson's. Let's look at, all right, let's spend some time on psychotherapeutics. So psychotherapeutics is pretty fun, but then again, we have different concepts of fun. Get this going. So it's a large umbrella term, psychotherapeutics. A large, broad band of illnesses or diagnoses fall under that umbrella. So it's a huge amount of emotional and mental disorders. When do we start treatment? Either it's distressing to the person, or it's interfering with their normal daily functioning, and they're asking for medicine treatment in addition to adjunct treatments for things like anxiety and depression. We generally recommend therapy at the same time as medicine. So the great thing about psychotherapeutic drugs, anything that acts on the brain, we often are not quite certain how it acts. We have a whole lot of theories, and that's because we can't just take a sample of something out of somebody's brain to see what's happening. But we think it's from imbalance in neurotransmitters, from dopamine and epinephrine, serotonin and histamine, GABA and acetylcholine. So obviously, we have a whole bunch of targets, neurotransmitter targets, where either we want to promote their production, maybe we want more of it, or we want to keep it around in the neurosynaptic cleft for longer and block the enzymes from breaking it down, or we want to what they call potentiate, meaning like be a helper to the way that neurotransmitter maybe. When I think of a potentiation, I think of someone like assisting them over to the neurotransmitter, helping them along to do their job. It's a very simplistic way to look at it, but it helps. Oops, backwards. So you should know the three main emotional and mental disorder categories, especially that we are covering. So we talk about anxiety, and then affective disorders and psychoses. And then so there will be meds for anxiety, meds for affective disorders, and meds for psychoses. So as far as anxiety, there are 6 major persistent anxiety disorders. So we're not talking about something that's short-lived or intermittent. It's something that people live with, like generalized anxiety or OCD or PTSD. People often have anxiety and haven't been diagnosed with a generalized anxiety disorder. But if it's persistent, it's time to get that diagnosis and get a treatment. So just recognizing that these are persistent anxiety disorders out there. When we talk about affective disorders, we're talking about mania and depression, which are the opposites of the teeter-totter. Mania being elevated and depression, everybody knows. And then people who vacillate between mania and depression have bipolar, right? They have the fortune of swinging back and forth and just feeling like things are really out of control. And then as far as psychoses, I should say psychoses, not psychosis. So the hallmark of a psychosis is that the person is so impaired that they've lost contact with reality and really can't participate in their own activities of daily living, whether it's getting places on time or following through on things, or even sometimes simple tasks like grocery shopping and bathing and things like that. So the ones we typically talk about, the big ones, schizophrenia, but there are depressive and drug-induced psychoses as well. So we talked about psychotherapeutics, those are the categories, and those are the topics within each of those categories. Under psychotherapeutics, there's a group of meds. So anxiolytics, meaning, it's an anxiety buster, antidepressant. Obviously, if it's a mood stabilizer, it's for those people that vacillate between highs and lows for bipolar. And then antipsychotics, we're talking about schizophrenia, but there are, of course, other uses for them. So we know these drugs are probably some of the most widely prescribed drugs because Americans are severely anxious and depressed. And so, unfortunately, because we can't scan somebody's brain to know what they're deficient in, whether it's a little bit of dopamine and a little bit of serotonin, or whether it's, you're vastly deficient in serotonin, or whether it's, we just can't know. And so treatment for a lot of these things is trial and error. And people who are awaiting relief often become very frustrated and give up. And so that's what leads to this non-adherence, is because they felt like they keep trying and they keep trying, and the drug keeps getting changed and they're not feeling better. And then, so we add on another drug and they're still not feeling better. And it's very understandable that people just stop taking it. Like, screw it, I have all these side effects. I have sexual dysfunction and I can't sleep, and whatever the side effects of the drugs are, and I still feel like crap. Why am I taking it? Let's talk about anxiolytics or anti-anxiety meds. Just being familiar, because that's the term you'll see on quizzes and exams, is anxiolytic. We'll talk about a couple of classes. Obviously, we discussed benzodiazepines in what context. They're what type of med? They're not an opioid, and they fell under what?
Antidepressant for central nervous.
Central nervous system depressant, right? Thank you. So we talked about them under central nervous system depressants. So they should be familiar to them. We'll touch on a few of them. And then I've chosen, but also the book was chosen, buspirone, which is not a benzodiazepine. And we like them because they have a lot of benefits, non-sedating, non-habit forming. But let's kind of look at them. So benzos, the book says largest and most commonly prescribed anxiolytics. I beg to differ. It's probably used to be the most common. We really are pushing away from benzodiazepines because they're highly addictive and they are central nervous system depressants, so they have a lot of side effects. We are going with some of the newer medicines for if we're talking about a mood-related disorder. Obviously, there's uses for benzodiazepines if we're talking about muscle spasms and if we're treating alcohol withdrawal to prevent seizures. And there are times that it gets used, but as far as like anxiety, just know that it's out there. We might give it short term while people get stable on another drug, but not long term. So we don't like it. These are things that you should already know because of its decrease. It decreases our central nervous system activity. So we're at risk of all of these bad things that come with it. This should not be anything new. They should not be new that alcohol and all CNS depressants have an additive or a synergistic effect depending on what we're combining with it. These are some of the common ones here: alprazolam, clonazepam, diazepam. These other ones are not common, but that's what was in that particular photo I found. Overdose happens when people can't clear the drug, right? Or so in addition to taking it with something that already suppresses your central nervous system, people with any sort of impairment in their ability to metabolize or eliminate the drug, kidney or liver, are at risk for toxicity and adverse effects, more likely to have more severe adverse effects. So we already talked about what's the treatment for a benzo overdose. Everyone already knows that, flumazenil. So let's have a quick review of alprazolam. It's the shortest acting on the market. It's the one that we give like pre-procedurally if somebody has a claustrophobia, they need to get in an MRI, something real short, quick onset and out of the body, short-term relief. It does have a few other uses, but this is generally what we're using it for, short-term relief. Same central nervous system depression, same sort of interaction with central nervous system depressants, and unfortunately oral contraceptives. Benzodiazepines have that interaction. So obviously you need to kind of file that away as a teaching point. If you have a patient who may be started on a short course of a benzo while they're starting another mood related drug. So sometimes we'll give somebody a benzo in the beginning until the other drug kind of gets going, and then we'll take that drug away, the benzo away. So in that period, nobody wants to get pregnant because if you thought you were depressed before. All right, Ativan, I chose this one, lorazepam, because it's intermediate acting, right? So we've got a short acting, we've got an intermediate acting. Has lots and lots of uses. You'll see this a lot in the hospital, especially because we can give it IV push. Anybody who's acting agitated or hallucinating or combative, little Ativan goes a long way. We use it in mechanical ventilation if people are agitated, and then in alcohol withdrawal or to prevent alcohol withdrawal while somebody's coming off. So a few good uses for it. This is a long acting, so short, intermediate, long. Remember this half-life is anywhere from 40 to 200 hours. So it really hangs out in the system long. We don't use it a lot for anxiety because of its half-life and its dependency. I mean, it still can be, but it's not our favorite drug. We know because it's long-acting, it's helpful with alcohol withdrawal. Because it's long-acting, it's helpful if somebody's having those uncontrolled seizures where we can interrupt it. And then this drug lasts a long time so that the seizure doesn't come back while things are getting figured out. And an adjunct for skeletal muscle spasms. Yep, kidney and liver. Alcohol and oral contraceptives. Guess what you should know? Alcohol and oral contraceptives. We like buspirone as an alternative for anxiety because it's a non-benzodiazepine, but in clinical studies, large-scale meta-analyses where they've taken a whole bunch of really quality studies and analyzed that it's just as effective as a benzodiazepine for anxiety without all the central nervous system depression. So it's a really great drug. Unfortunately, it has to be taken multiple times a day. That's the only downside. It's like 3 to 4 times a day. We like it because it's not a central nervous system depressant, so it doesn't sedate, it doesn't cause addiction, but there are some other things that can come with it. This paradoxical anxiety, nausea, headache. Less nausea is probably more common, but just knowing that it is possible. I had a little old lady with kind of psychoses, and she had dementia. We were trying to figure out whether there was an element of anxiety in it. So I tried her on this drug, and she went wacko because it had paradoxical anxiety for her. So yeah, that was not a good one. All right, so that's sort of like anxiolytics. We have benzodiazepine and then non-benzodiazepine, talked about buspirone. Now we go to mood stabilizing. So usually used in our case, we're talking about bipolar. Now, that's the main one out there, and the main drug that has the oldest one on the market is lithium. We'll talk about lithium, benzos, antipsychotics, and antiepileptics. There's all these ways to treat bipolar, and it is very much a trial and error, and it's horrible for the person waiting to get stable because you have the side effects, you're still having mood swings, and you feel like you're never going to get stable, and the drug has to get changed. And some of the drugs cause weight gain, and some of the drugs, it's just never ending. So lithium, I threw old Britney Spears up here because of course that's what she was put on for many years of her forced treatment was lithium. So visual to help you remember lithium. It's really, really old drug. It's a great drug, but unfortunately, like many old great drugs, there's reasons why it's not always the first choice. It has a narrow therapeutic range, right? So a narrow therapeutic range or a narrow therapeutic index. Go back, what does that mean?
Very small area where it becomes toxic.
Right, there's a small area between beneficial and toxic. So that's not so great for somebody who's swinging from, mania to depression to mania to depression, is that they have this tiny little range, and it's very easy to either you have mania and you feel like you're feeling so good that I don't need this drug anymore. Look, I feel so great. I can stay up for 36 hours and I can finish all my homework assignments. Or then you swing down to depression and you just can't get out of bed. You just don't want to take a pill. And that's why it's fallen out of favor, is because it's got that narrow therapeutic range. So you should know the therapeutic range, signs and symptoms of toxicity, and then the key lab that we talk about with lithium is sodium. So if you have hyponatremia, low sodium, people are at risk of having seizures. And that's just the last thing you need for your patient on lithium.
Big question.
Yeah.
On lithium, how often do you have to do the
So it's more frequently when you're starting out, and then once you're stable, as long as it's like anything, it's very patient specific. If a patient has been stable on it for a long time and doesn't have a lot of med changes and they're reliable, you may check it every 6 months along with the sodium. But if somebody is vacillating, and you're making drug changes, or somebody's adding on another drug like a diuretic that might cause them to lose sodium, you're checking quite frequently. So there's no one right answer. So the most serious adverse effects are cardiac rhythm issues. And that's most likely due to what lab value? Low sodium. Yeah, low sodium. Low sodium is links to a lot of things. So some of the adverse effects are that people, like we say, that make people not like it is because it makes them very sleepy. They feel like they can't get things done and they really enjoyed the mania. They just hated the depression. There is the risk, and you'll see this come up in other diseases, something called choreoapatoic movements, which is sort of, if you know anything about Huntington disease, it is sort of involuntary movements of the body in a way, they're kind of wave-like. So choreoapatoic movement, ataxia. So ataxia is a general term meaning a problem with their gait and hypotension. And then long-term treatment can suppress thyroid hormone. So a whole bunch of stuff. Look at all these potential bad things from this drug. It's a great drug and there are people on it, but a lot of things to be monitoring. I just threw this one in. I don't think it'll show up on the exam, but they threw it in on the master one that the college produced. Vraylar, you'll probably see commercials about it. It's an interesting drug that acts on both dopamine and serotonin. And if you look at how it functions, so when we have a lot of dopamine and serotonin, it helps to inhibit and acts as an antagonist. But when we have low levels, it helps to propagate and acts like an agonist. That's a really weird drug that can do both. If you don't have enough, it gets you to produce more. And if you have too much, it suppresses and makes sure that you're receiving less. There are lots of risks with it, stroke in the elderly, and some movement disorders that we'll talk about called neuroleptic malignant syndrome, which you have to know, and tardive dyskinesia, which you have to know. All right, so before you give lithium to a patient, which is the most important lab value, so thank you, said it 99 times, you can expect that this will show up many more times. It's always sodium when it comes to lithium. All right, so that was mood stabilizing drugs, bipolar disorder. This one, antidepressant drugs are in the affective disorder. So we're talking about, we use antidepressants for major depressive disorder. This is the term that is called dysthymia, which means it's not quite a low-grade depression. It's not quite a major depressive disorder. It's kind of just low level. I don't know you're depressed, right? We might use antidepressants as an add-on for schizophrenia. There's lots of unusual uses for some of these drugs, like eating disorders, personality disorders, things like migraine headaches, PMS, hot flashes. So this class of drug, sometimes we find out it benefits a lot of other conditions and we start using them for the adverse effects. Right. Yeah. But a patient's taking, so you should have read and be familiar with selective serotonin reuptake inhibitors. This should not say selective SSRIs. It should say SSRIs, which are selective serotonin reuptake inhibitors. And so the term means that it keeps serotonin in the synaptic cleft, right? Everybody remembers our synaptic cleft. It's our little neuromuscular or neural junction. That's two neurons, right? This is the neurosynaptic cleft. You have the little release and you have the receptors, and keeping it around longer means it's available to bind over and over. All right, so selective serotonin reuptake inhibitor. All right, so for the when patients are taking this class of drug for the first time for depression, what's the most important thing that we should teach them about and monitor for during the first few weeks of therapy? Do these drugs cause hypertension, and are they at risk for hypertensive crisis? Is it suicidal thoughts? Are they at risk for seizures, or are they at risk for orthostatic hypotension? Right, it's suicidal. Pretty much, it's pretty well known, and especially in children, that we need to always be educating patients and family members that in some people, studies have shown there in the beginning stages, there can be an increased risk of suicidal thoughts and behaviors. So if anyone's noticing these things or feeling these things, you should call somebody right away. You don't stop the medicine necessarily, but you reach out to your provider right away. And we're always providing people with the suicide hotline and all of those things.
Question with regards to this thing, is that in children? So this drug is used for children?
Some drugs are used for children.
How do you see a child wanting to commit suicide?
Yes. Yes.
How do you?
How do you see them?
How do you determine that? I mean, by children, I'm talking maybe like 5-year-old.
Less likely, it's more when we're talking about children and young adults, we're talking in the, preteen to teen.
Okay, so not children.
Most antidepressants are not approved for that young.
That was my question.
Sorry, yeah.
If we're talking children or adolescent.
We're talking preteen and teen. So 9, 10, 11, 9 is even an appropriate age if the drug has been approved. Because we have 9-year-olds with severe depression who commit suicide. Who die by suicide, correct terminology. All right, so things you need to know for an exam and for your patient, that these things you don't just take a drug like insulin and you have the benefit in X amount of minutes or hours. These drugs take weeks to even see a therapeutic benefit. That's why people give up on them, right? If something is giving you sexual side effects, and selective serotonin reuptake inhibitors are known for their sexual side effects, causing impotence and decreased libido. Awful for people of a particular age who have a particular interest in being human, it can be a big deal. So we have to tell them ahead of time what to expect. You have to find the right way to phrase this. What we know is that these drugs can take some time before we see the benefit of it. You may start to feel better earlier, but if you don't feel any better by your 6-week follow-up, that's normal. Expect that visit that either your dose will be increased or will be changing it if your side effects are intolerant or adding something on, but setting up expectations to keep people adherent to the treatment regime. Usually we have several dose titrations upward. Start at the beginning dose, wait 6 weeks. They don't come to their follow-up visit. Reschedule them, they come back at 10 weeks. Feel a little better, but not great. Dose increase, right? I mean, it's this really long process. They come back at another 6 weeks. Well, now, they have side effects if they have insomnia, and this is intolerable. So it's just an ongoing process. The rule is that we should never be using antidepressants alone. In fact, psychotherapy or any sort of talk therapy, desensitization therapy, eye movement therapy. There's all sorts of therapies. Generally, those are first line, but people want a pill. So if they're starting with a pill, they should also start with some sort of psychotherapy, whatnot. These are the antidepressants that we review. There's a lot more than this, but this is what we review. Tricyclics, which were early on the market, MAOI inhibitors. These are the antidepressants. We saw MAOI inhibitor, MAOI-B inhibitor with another disease state. And I said, these are not the same MAOIs. Do you remember what disease state that was? So go back and review. And see if you can find where MAOI showed up in drug treatment that was not related to mental health. Yes. Then we have what we call second generation antidepressants. These were the first generation, meaning they're the old ones on the market. We have SSRIs, we have SNRIs, serotonin, norepinephrine reuptake inhibitors, and we have a lot more than that, but we'll just stick with those. Typically, we used to use tricyclic antidepressants a lot 40 years ago, 50 years ago. They were probably the first drugs on the market. We hardly use them at all anymore. And we use SSRIs as first-line therapy. And that's because they have a lot of side effects. So you can recognize a tricyclic if they end in tryptamine or ipramine. Those are your kind of your key clues of how you recognize them. How do they work? Well, if we can keep the neurotransmitter in the synaptic cleft for longer and not have it broken down, then it has more opportunity to be used at the postsynaptic receptor. What we think is that if we keep enough neurotransmitter that will correct the low levels. These are all just how we're thinking it works. We really have no idea, but that's our best thought. So what do we use tricyclics before? We use them for depression and OCD. This imipramine gets used for childhood enuresis. What's enuresis? Bedwetting. Yeah. So we're actually using this. Has nothing to do with a mood disorder. It's being used because of its mechanism of action and it's one of its adverse effects. We're using it for that, for childhood, for bedwetting. We use it as an adjunct for some chronic pain conditions, especially if it interferes with sleep, because tricyclics are very sedating, which is why we don't like them so much. We also they have a side effect of increased appetite. So sometimes they get used for people who have anorexia nervosa because of that appetite stimulation. A lot of people don't want to have an appetite, right? And the last thing you need to do is gain weight. And so because they're sedating, like I say, we might use them for people who have chronic pain and it's preventing them from sleeping, and maybe they have depression at the same time. So you get a three-fer. You've got somebody who has depression, and maybe it's their chronic pain that's causing their depression and their chronic pain that's causing their sleep issues. So we may be doing something else for their chronic pain, but we might add on a tricyclic because it can hit three of those targets. They do have their uses. Unfortunately, all of those adverse effects that we mentioned on the previous slide, like sedating and increased appetite, they also cause orthostatic hypotension. We have sexual side effects, other things in the books, and they're really bad in the older adult because of all those, the sedation, the increased risk for falls, the postural hypotension. That's why they're bad in older adults. We don't need grandma falling. Unfortunately, we don't have an antidote for tricyclics. So the statistics say that people who overdose on tricyclics and have EMS activated, 70 to 80% die before they get to the hospital because we don't have an antidote. It's another reason they're really deadly. So it's another reason we're very conservative in the use of them. They are not first line for depression in any way, shape, or form. They cause central nervous system and cardiovascular system depression. There are some things that we do, like we try inactivated by giving activated charcoal if it's within a couple of hours, and we try to change the pH of the urine, and we're trying to manage some of the consequences, but yeah, pretty deadly. So amitriptyline is the prototypical example of a tricyclic antidepressant. It's the oldest on the market. Again, it's originally was for depression. More often now, we're using it for insomnia when other treatments have failed. Some of those sleep disorder treatments that we talked about. If they've all failed and some other drugs we'll talk about have failed, you might try amitriptyline. Again, it's good with pain disorders as an adjunct treatment. You don't take it in pregnancy. It has a whole bunch of anticholinergic type side effects, dry mouth, constipation, urinary retention, blurry vision. And we'll get to anticholinergic next week. All right, they want you to know about herbal products. People do take herbals for their symptoms. St. John's wort is known as herbal Prozac. And what we know is that there is some benefit from it because it acts on serotonin. However, it's the same problem with all herbal supplements is that you don't know the quality of what you're getting, you don't know the quantity of what you're getting, you don't know the consistency from bottle to bottle. And so what we find, according to studies, it isn't consistently effective for those reasons. And there are drug interactions, some pretty significant ones, anticoagulant, dysrhythmia, heart rhythm medicine, and then HIV medicine. So it's not innocent, has interactions and can lead to something called serotonin syndrome. And yes, you will have to know what serotonin syndrome is. Let's take a quick break. We'll get up and come back by 4:30. We'll talk about MAOIs. Shake it off, shake it off. Hey. Oh, no, didn't get you. When did you come in? Okay, yeah, once I get started, I'm blocked out. Toria, thanks for letting me know.
Dr. Z.
Yeah.
When I first was diagnosed with celiac, they put me on amitriptyline for some pain.
Did they? I mean, it's got a million potential use.
I hated it because if I didn't take it like every day religiously, my mouth gets so dry. It was the worst, so I just stopped taking it.
See?
My good
Stop because of the side effects.
Yeah.
There's not.
We'll be watching a commercial, and my husband will go, "They have these side effects for this," and it's just like a list. They keep on and on.
Yeah, you're the one sitting right next to her.
All right, people are not back, but you're the dedicated ones. So tricyclic antidepressants was the first class of old drugs. Monoamine oxidase inhibitors are the next class. So what you learn is that monoamine oxidase is an enzyme. That's the first thing to know. Monoamine oxidase is an enzyme. What's the job of an enzyme? Breaking something down. So if we can block the enzyme from breaking something down, we keep the something for longer. Pretty logical how it works. So monoamine oxidase is the enzyme involved in breaking down norepinephrine, serotonin, and dopamine, all these really important neurotransmitters involved in mood. So if we can take a drug that blocks this enzyme, we keep norepinephrine, serotonin, and dopamine around longer, which we think helps with mood, right? There are some non-selective MAOIs that I didn't list up here, because they're really old school. They're the one that we talk about that's a selective, meaning it's more selective regarding neurotransmitters involved in mood. So selegiline, the oral form we talked about being used for Parkinson's. This is a patch form that's being used for mood. The thing that you have to know, to get to it, oh yeah, there are some dietary restrictions with monoamine oxidase inhibitors, MAOIs, which is why they've fallen out of favor as antidepressant, because there are foods and fluids that can cause a hypertensive crisis. People can stroke out, not necessarily what you want when you're already depressed. So the key chemical within it is tyramine. So any food that's high in tyramine can cause a hypertensive crisis. That can cause a brain bleed, which is a stroke. It can cause coma, can cause death. So there are lots of things that contain tyramine. The classic ones that we talk about are aged cheeses. So this risk of MAOIs with tyramine gets called the cheese effect by slang, but it doesn't happen with fresh cheeses. It's just the aged cheeses. It happens with anything that's smoked or pickled or aged as far as a meat or poultry. So no sausage, corned beef, salami, no pickles, pepperoni. I mean, all of a sudden you have all of these classes of things you have to avoid. Certain red wines. Good God, if you can't have a charcuterie plate,
Right?
glass of red wine, no wonder you're depressed. So this is why this particular class of meds, I think I met one person who was already on it. They already knew all of the, I mean, they just didn't have any problem with sticking with their food restrictions. So they just stayed on it because they were stable. But nobody ever gets started on this drug anymore, really, unless we're really out of options because of all of this tyramine related food we have to avoid. Good heavens. So this particular selective MAOI, selegiline, remember it orally was for Parkinson's. This patch is used for major depression. This is another one where we have to have people avoid heat because heat speeds up the absorption from the patch, and then you get too much and you're subject to all the adverse effects of the drug. So that's tricyclic antidepressants and monoamine oxidase inhibitors. Older drugs should know about them, know the risks. We are more likely to use these newer, what they call second generation antidepressants because they have less drug or drug food interactions. That's one of the big reasons to use them. Less deadly than tricyclics, but people can still take a lot of anything that's deadly. Again, they still take weeks to months to see a real therapeutic benefit. These are first line. So basically the name of them, selective serotonin or serotonin norepinephrine reuptake inhibitors, SSRI, SNRI, they tell you what neurotransmitters they're acting on. SNRIs may have some dopamine action as well. So learn your neurotransmitter, serotonin, norepinephrine, dopamine. Second generation antidepressants get used for things other than depression. Okay, they get used for depression. We might use them in bipolar. We might use an anti-anxiety and then an antidepressant medicine rather than using lithium because of all of those reasons we talked about with lithium. So we might use that as one of the components. If the drug happens to cause suppressed appetite, we might use it there. If it causes an increased appetite, we might use it there. These were all the generalized anxiety disorders that we talked about. So antidepressants get used in anxiety because anxiety and depression are the opposite sides of the same coin. It's just a different manifestation of the same chemical imbalance. Anxiety and depression can be treated with both anti-anxiety or antidepressant classes of medicines. So don't get confused that we say, well, that medicine is it's an antidepressant. We use it in anxiety as well. PMS, neurologic disorders, substance abuse. We'll talk about some of these. So I said you have to know about serotonin syndrome. So because these drugs act to keep serotonin around longer, the risk is that you get too much serotonin. And there are harms from having too much serotonin. And it manifests as serotonin syndrome. which is all of these things, delirium, agitation, tachycardia, sweating. I mean, it can look like a lot of other things. It could look like somebody maybe who was taking a central nervous system stimulant. So that's where you need to be aware of what medicines they're taking, so that you might be able to help pick out if this is serotonin syndrome. So know your symptoms and why it happens. More severe cases of serotonin syndrome cause seizures. What's rhabdo? Rhabdomyolysis. Key is in there.
Muscle stiffness.
Heart.
Muscle breakdown. So you start to have breakdown of muscle tissue. It releases of chemicals from the muscle tissue. And it's a cascade that gets worse. It can cause heart failure and your heart to go wacko. And what's disseminated intravascular coagulation? What does that mean? DIC. Anyone ever heard of DIC? Basically, where your body just decides that you're going to make clots everywhere throughout your body. So it's disseminated, meaning widespread, intravascular throughout our entire vascular system, coagulation clots. That's pretty serious. That'll kill you. What are some interactions we have to watch for? So a lot of these second generation antidepressants are highly protein bound. Okay, we talked about protein binding over and over and over, and why protein binding is so important. And you have one highly protein bound drug, it is bound to have interactions with other highly protein bound drugs. And one of them is going to win and bump the other one off. And then you have more of that other drug floating around that is super therapeutic. Some rules about these is that generally we need a washout period if we're changing classes of antidepressants. So meaning if we were on a tricyclic and we're going to switch to an SSRI, we're going to allow this one to come down and then slowly start up again. We're not just going to start here and then start the drug there, because you're going to get this super therapeutic side effects and whatnot. We need this kind of washout period. And of course, we talked about St. John's wort, and because it acts on serotonin, what's the risk? What's the syndrome we said you could have? Serotonin syndrome, because St. John's wort acts on serotonin. SSRIs, SNRIs act on serotonin. That's where we can have that interaction. So this is the oldest SSRI on the market. Everybody knows Prozac, at least have heard of it. Fluoxetine is a generic name, super old. You can get fluoxetine for like 5 cents a pill or less. So lots of indications, including depression, and then these are anxiety disorders, and it gets used for in bulimia. For some reason, it tends to stabilize some of those signals that are pushing people to binge and purge, and PMS with mood type symptoms. We like it because, remember, this one has a really long half-life. If you've got depression or anxiety, it's hard to remember to take your medicine every day. So things with a long half-life are good for people who have a hard time taking things consistently. If you miss one day, it's not such a big deal. Where if your half-life is like 36 hours, it's a fairly big deal. And anything that you're taking to treat anxiety or depression can worsen anxiety or depression. You're going to find out with a lot of drugs, anytime you're taking a drug for a certain reason, can actually make it worse. So it can cause anxiety, insomnia, just go down the list of all the things that can happen with taking an antidepressant. The next one I like to talk about is citalopram, because it's pretty common on the market for depression and OCD and some anxiety symptoms. You can't really stop this suddenly. In fact, you shouldn't stop any antidepressant suddenly. But in particular, this one causes discontinuation syndrome, which are just a sudden onset of flu-like symptoms, achy and feeling fatigued and feverish, and like you just need to go to sleep. It's uncomfortable. One of the big red flags of this one is that it can cause some heart rhythm issues. The specific one is called QT prolongation, and QT is the interval between depolarization and repolarization. And what we know if that gets too long, we are at risk for a deadly arrhythmia called torsade. And so if people are taking multiple drugs that have an adverse effect of prolonging this interval, they can end up with deadly heart rhythm. Very common to have sexual side effects with all SSRIs, which is one of the reasons, one of the downsides of this class of drug. They're very effective, but if you have a population who's not interested or not sexually active, they often tell you, well, I don't care about that. That's fine, I'll take this drug. There are lots of people who say this is intolerable. No, you know, I'm not playing this game. Duloxetine falls into the, this is supposed to have one S. No, it isn't. Selective serotonin norepinephrine reuptake inhibitor. This is the way we used to write it, SNRI. They're both correct, SNRI and SSNRI. So they act on serotonin and norepinephrine. Again, depression and anxiety, but duloxetine has great uses as an adjunct med for nerve pain. So just like gabapentin gets used for seizure and for nerve pain, duloxetine gets used for mood disorders and for nerve pain, especially diabetic peripheral neuropathy. It's a good one. Again, same types of side effects, dizziness, drowsiness. It just depends on the patient, and sometimes it may go away and sometimes it may not. So you have to be careful. Where did we see this class of drug, triptans? What were they used for? What condition? Migraines, right? So it wouldn't be uncommon for someone to have depression and migraines, right? They could go together. Maybe the issue with their migraines really contributes to the depression. But there is a drug interaction between taking an Imitrex, a sumatriptan, and taking duloxetine, because it increases the risk of that serotonin syndrome with all of those 2 slides of manifestations of serotonin syndrome. You have to be careful with if somebody has not treating their specific closed angle glaucoma. So this is uncontrolled if they're not on the appropriate treatment. Yeah, adjunct for pain, awesome drug. All right, let's talk about bupropion, which is not in any of those particular drug classes. It actually is a dopamine reuptake inhibitor. So we saw serotonin, we saw norepinephrine, now we see dopamine. So originally it was out there for depression. It also is used for anxiety, but now it has a clear indication in smoking cessation. In fact, the algorithm for treatment of smoking cessation includes offering bupropion. So you will see that come up as a question like a patient is taking bupropion. They say they have no issue with a mood disorder. So what could they possibly be taking it for? The indication is smoking cessation. We use it sometimes because it doesn't have the sexual side effects that SSRIs and SNRIs have. So you've told a patient to, who's going to start on fluoxetine or sertraline or Cymbalta about the sexual side effects, and they say, no way, no way. You can expect that this would be the next drug choice out there, bupropion. All right, let's talk about mirtazapine. It falls as an atypical antidepressant. It's really used more as a sleep medicine or people who have problems with depression that affects their sleep because it's really sedating. So sometimes we use mirtazapine not for depression, we use it for the sedating properties because it helps people sleep. Another adverse effect of it is it's an appetite stimulant. So you can imagine there are certain people who don't want to have an increased appetite. If you have anxiety or depression, perhaps you're not wanting to feel like you need to eat all the time. However, there is a population where that is important. We have lots of little old ladies, little old men who kind of have the dwindles. That's my technical term for getting older and just losing your appetite and kind of wasting away. And they're not sleeping well at night. So this is a great drug because it stabilizes mood, it helps with sleep, it gives grandma or grandpa a little bit of an appetite so that maybe they would consume more calories to keep their muscle mass so they don't fall. It's a pretty good drug. Some people get a little bit cuckoo dreams on it. Say this one. Lady and her abnormal dreams. Again, lots of interactions. Just always know we are careful with anything that depresses the central nervous system, and alcohol. That's just a given. If that's a medicine that's going to put you to sleep, you know that it's depressing your central nervous system in some way. So be careful. Trazodone is another one that we use often for its sleep effect. So mirtazapine and trazodone. Really, even though they're fall in the antidepressant category, more often we're using it for their sleep effects. It is strongly sedating. Unfortunately, it can worsen cognition in older adults. So we're weighing the benefits and risks in the older population with desire for sleep. What do you know about the structure of sleep? You get more or less sleep as you age. Less, right? You get less sleep as you age. And there's some people as they age, it's really bothersome to them, or they're really just not sleeping for whatever reason. You've already done the keep a sleep diary and don't drink coffee after noon and don't exercise in the evening. And now we're starting to look at some of the medicines maybe that would help them sleep. Just being careful with the older adult. All right, so let's talk about some of these things. We're teaching a patient who's prescribed the selective serotonin, selective SSRI, that's twice I've written that. Which statement will the nurse include? An SSRI will work faster than the older tricyclic antidepressants. SSRI will have an immediate beneficial effect on the patient's depression symptoms. SSRI will not work well for severe cases of depression. SSRI may take several weeks to have a beneficial effect. Yeah, right? We've said it probably 7 times now that mood disorder medications, especially antidepressants, whether it's MAOI or TCAs or SSRIs, they take weeks to months. Typically 4 to 6 weeks is the kind of the time frame we tell people that to expect to begin to feel an improvement in symptoms. We like to give them hope. You may feel better sooner, but if you don't, it's not unexpected. All right, so we have anxiolytics, antidepressants, and then antipsychotics. So antipsychotics really get overprescribed in dementia-related population. When we're trying to deal in a nursing home environment with dementia-related behaviors, however, there are huge red flags on that, and like all of the monitoring institutions are watching for that. So really the appropriate use for antipsychotics include schizophrenia, psychosis, bipolar. We might add it on for somebody who has refractory depression, who's just not doing well with other drugs. And then there's some other funny little uses for it, like Tourette's and hiccups. They're also known as tranquilizers or neuroleptics, so that's common terminology like tranquilizer. We're going to call them antipsychotics. So we have, just like antidepressants, we have a first generation and a second generation, and then we have some atypicals, and same thing with antipsychotics. Here's what I recommend you do out of class in order to kind of make sure that you're aware of the side effects of traditional antipsychotics, the side effects of the atypicals, the SSRIs, the MAOIs, in order to pick out what's different. A lot of them are similar, you know, whether we have sedation and whether we have increased appetite, but picking out what's different from them. So how do we think antipsychotics work? So we are thinking it's acting on dopamine receptors so that dopamine levels in the central nervous system are decreased. And in that way, we're kind of lowering things down. That's why we think of them as tranquilizers. It makes you more tranquil. You've got schizophrenia, everybody around you wants you to be more tranquil. So what is schizophrenia, first off? So just like bipolar has positive, what we call positive affect and negative affect symptoms, where you have the highs and the lows, schizophrenia has what they call positive and negative symptoms. So I don't know why we consider it positive, but hallucinations and delusions and not being able to think about things correctly as far as how things connect. Or I have a patient who really believes that his parents were kidnapped and replaced with new parents, and that his mother is being held captive and being raped by his current replacement father. This is schizophrenia, right? Just kind of out of touch with reality.
They call that positive?
And that's considered a positive. Yeah,
they think it's real.
yeah, well, yeah, because it's a brain dysfunction, and what's real is what you think it's real. That's how your brain is saying your reality is. Negative symptoms are sort of the downside, the down in the mood, like people can be very almost to the point of catatonic, where they can't come up with words or speak. These are some of the other symptoms, like just completely withdrawing. And you can see why people would turn to illicit substances, to drug abuse, in order to self-medicate some of these symptoms. So we know that all of the antipsychotics can help with the positive symptoms, but not a lot of them help with these symptoms. It's a really difficult disease to treat. So what we came up with the first generation antipsychotics being good with these, we came up with the second generation newer meds that are a little bit better with the positive and the negative. So again, those are the positive, those are the negative. I don't think I want any of them.
It's positive in the view of the patient?
No,
or-
they are considered positive symptoms classified diagnostically. If someone has a hallucination, it's categorized as a positive symptom because, and then we know that first generation antipsychotics may treat that if they don't have this category of symptoms, right? It's just a categorization.
It's not anything to do with good or bad.
No,
That makes
nothing to do.
Okay.
Nothing to do with good or bad, right? Just a classification, dumb. I mean, you can think of negative, like, okay, they're positive in the, like thinking about going up, like uppers, where you might, you know, this might be what happens if you're taking an upper. That's how I think of positive. And how would you be if you were taking a downer, right? You have a blunted affect, and you might be more withdrawn. That's how I think of them. So the most common psychotic illness is schizophrenia. However, we do use antipsychotic drugs for anxiety and mood disorders and bipolar disorder. And then there's one particular one in here that's prochlorperazine that you use in the hospital just for its anti-emesis, anti-puking med. So great drugs, lots of problems. So we have blood cell line issues where we don't come up with, we fail to produce enough white cells. And the drug is causing a destruction of our own red blood cells. Can't be very healthy if you're not having red cells and white cells, right? You're not a very healthy person. It's not everybody, but these then would tell you what labs you would need to monitor on a regular basis. We know that they affect the central nervous system, and then these are some of the syndromes that are associated with antipsychotic drugs. And the stars are there because, yes, you have to know them. So neuroleptic malignant syndrome is a really high blood pressure with well, it's high, but it also can vacillate to low, but it's often just high, with a really high fever, with a breakdown of muscle tissue. The high fever, what does that sound like that we saw with anesthetic drugs? Malignant hyperthermia, right? So very similar, but this is related to taking an antipsychotic. Neuroleptic malignant syndrome. Extrapyramidal symptoms are, so these are involuntary muscle movements as a result of the drugs, the antipsychotic drug you're taking. So they can look similar to the movements of someone with Parkinson's. They can be just generalized muscle restlessness, where people are just moving all the time, painful muscle spasms. And so if you remember, we said that this was there in Parkinson's for some of the muscle movements, and that we also used it for extrapyramidal symptoms that were a side effect of antipsychotics. Here it showed up again. So neuromuscular malignancy syndrome, extrapyramidal symptoms, and then tardive dyskinesia. There's actually a little chart that often the nurse will fill out as they're observing the patient and asking questions that talks about all of these kind of muscle movements and how distressing it is and how much they notice it. But tardive dyskinesias are a potential adverse effect of being on antipsychotics long term. So you get these involuntary facial and muscle, oral and facial movements. And can you imagine if this was, you're just out there and you have no control over it? And, sometimes that's, somebody doesn't notice, they just think the person is psychotic. No, this is a symptom of a tardive dyskinesia, which potentially, if you leave it long enough, is irreversible. Again, this particular type of wave-like movement of the extremities, and these side effects, tardive dyskinesia is associated with long-term treatment. That's the treatment for it. I haven't seen it show up on any exam, but it's always good to know. Other things we have to watch for. So in addition to agranulocytosis and movement disorders and tardive dyskinesia, all of these potential adverse effects, they have effects on our body becoming resistant to insulin, weight gain, elevation in cholesterol levels, which those three put together is called metabolic syndrome, which is a precursor to diabetes. So people on these drugs, we have to, in addition to checking the CBC, we're also watching their A1C, we're watching their cholesterol levels, because they eventually become diabetic. But if everything else is doing fine, they're doing well on the drug, diabetes, I guess, is tolerable. So this is an old school, everybody probably's heard of Haldol or haloperidol, old school antipsychotic. It gets used in palliative care a lot, where we're treating psychosis related to late stage disease. There is a place for it for some patients if they can tolerate the adverse effects. We like it because look how many different ways it can be given. And we can give it an injection. We like it because it can be injected in patients with schizophrenia, and it's long acting. And if they're people with schizophrenia or with a lot of mood related disorders, have issues with sticking with treatment regime. That's why we use drugs that have drugs or routes of drugs that have a longer half-life. So you don't have to know all of these, but kind of recognize some of these names. Some of them you should know. Risperidone, olanzapine, quetiapine. These are pretty much the first ones that were on the market as these atypical antipsychotics. So here's kind of a comparison. Some of them have increased risk, some of them have decreased risk. Basically, we pick apart what's the patient's risk factors and which one would fit best, and we hope for the best. There are risks with QT prolongation again. So if you remember with citalopram, there was a risk of QT prolongation. So if you take another drug with it, it increases the risk of this heart rhythm problem. How do they work? Let's see. More specific for a particular form of dopamine and a particular form of serotonin. Same old neurotransmitters, right? It's not like it's anything new. There's not a new neurotransmitter. But we've learned to be the drug is very selective for certain neurotransmitters, which is why they are the next generation of antipsychotics. So out there is Abilify or Piprazole gets used a lot as an antipsychotic for schizophrenia, bipolar. That's the antipsychotic, that's the mood stabilizer, major depression, agitation associated with autism, has some of the similar side effects of atypical. We like it because, again, it can be given extended release IM injection, Abilify, great with schizophrenia, great with bipolar, if somebody doesn't have to take something every single day. Here's another one, clozapine. We like it because it has very little association with these extrapyramidal symptoms, right? So less side effects. However, it does have the blood-related issues with suppression of white cell line and then hemolytic anemia. So our body, the drug breaking down red blood cells. So we're watching all of that. Risperidone, again, great schizophrenia drug. We know that it does help with the negative symptoms. All of the antipsychotics help with positive symptoms. The atypicals help with negative symptoms as well. As long as we keep the dose fairly low, we don't have those risk for extrapyramidal side effects. Here's the long-acting form. Here's an even longer-acting form. I would just recognize that it's an atypical antipsychotic, what it's good for, especially what symptoms it's good for, and that it does come in injectable form as longer acting.
So would you say the atypical psychotics are good for some negative?
Atypicals are good for positive and negative, where the first generation antipsychotics really only treated the positive, right? The positive symptoms. So the hallucinations, the erratic thinking, disconnect with reality. So
What drug do you take if your pharmacology classes make you psychotic?
there you go. Good question. What would you like to take?
Hammer to the
I don't know, you're at the top.
You don't need an
I'll write
antipsychotic.
something out.
Just need a good night's sleep and then to get organized. All right, so we're gonna go over chapter 16 in the form of a bingo game. Come and take your bingo card.
The 16 one.
16 is the one we just did. Come and take your bingo card, and you're also gonna need some, what are they called, chips or tokens or? Yeah, I don't need mark. We're gonna play to first bingo and play to blackout. You're gonna need some of these little chips to cover your spot.
Can we just mark it?
Oh, you can mark them. Hey, but then we don't get to play again. You can mark them, fine. You can be a party pooper. I'm playing with the balls and everything. I'm into playing bingo. Let's see, put my balls in the bingo cage. And what a downer. Really wanted to play that bingo game with chips. If only I had money to give out, like the, $5 to get a bingo or something. All right. Get organized. So I got all my things here. That goes there. Go down. All right, so we get a mark it with. All right, so we have our bingo prize, which is a Avalon Healthcare Group, courtesy of Kristen, filled with payday candy bars.
Who is mouse sandstone?
Who is, well, it's whatever they gave her, And then, of course, for the blackout, we have the nurse's survival kit. All right. So here we go, and it's, I'll just turn this on. Nothing to do here. Nothing overhead. What's that? It's being recorded. You can record it, but all of the question and answers will be posted afterwards. The recording will be posted. The only thing that's secret in this class are like the exams. Everything else you're free to learn and share. All right, so this gets to be fun. All right. The first question is, this is a potentially life-threatening neurologic emergency associated with the use of antipsychotics, which is characterized by high fever, 102 to 104, rigidity, mental status changes, autonomic instability. That includes tachycardia, labile or high blood pressure, and profuse sweating. Who knows what that one is? It doesn't matter. Just neuroleptic malignant syndrome. If you've got it on your card, feel free to put your token on it. The next one is, this drug is FDA approved as an adjunctive therapy for forms of Parkinsonism. It's also used for drug-induced extrapyramidal symptoms, prevention of dystonic reactions, and treatment of acute dystonic reactions. What is the drug? Approved as an adjunctive therapy for Parkinsonism and used for drug-induced extrapyramidal symptoms. Which one? No, it's a specific drug. MAOI is a class of antidepressant. Not buspirone. Does start with a B. Benztropine. Remember, it was under the Parkinson's meds, and then we just talked about it for the extrapyramidal symptoms associated with antipsychotics. All right. So if you've got benztropine, mark that one. Next one is benztropine. This antidepressant is an old drug and is the prototypical SSRI. It's used to treat depression, bulimia, OCD, panic disorder, and premenstrual dysphoric disorder. And it's great for people who forget to take meds because of its long half-life. Fluoxetine. Yes, fluoxetine. What's the brand name of fluoxetine? Even though you Prozac, right? Yeah, you got it. All right, the next one. If you've got fluoxetine, put it here. The next one says, one of the oldest this drug's used as a mood stabilizer, but it's used less now due to its narrow therapeutic range, adverse effects, including the potential for abnormal movements, cardiac arrhythmias, and seizures. Lithium, right? That one's in, you just picture Britney Spears. Poor Britney.
Leave Brittany alone.
I know. Free Britney. All right. All right. When patients are taking selective serotonin reuptake inhibitors, SSRIs, for the first time for depression, what is the most important thing to teach them and monitor for during the first few weeks of therapy? Suicidal thoughts. If you've got suicidal thoughts on your card, put that one in. All right, the next one. All right, let's see. This is one of the most commonly used SSRIs, but stopping it abruptly can cause discontinuation syndrome, which includes flu-like symptoms of insomnia, flu-like symptoms. It can also cause insomnia, nausea, imbalance, sensory disturbances, and hyperarousal. It has a problem with the potential for prolonging the QT interval, which can lead to a deadly arrhythmia called torsade. Citalopram. You go, girl. Citalopram. Let's learn our drugs. The next one. People who demonstrate swings from mania to depression are said to have this disorder. Bipolar. Good job. Good job, kids. All right. All right. This one, this antidepressant medication was originally indicated for a treatment of depression. Now is also used for anxiety and has an indication for smoking cessation. It's sometimes added as an adjunct antidepressant for patients having severe sexual adverse effects from SSRIs. Bupropion, right? That's a whole lot of things about it, but you got the drug. Bupropion. Come on, big money. All right, this term, B-U-P-R-O-P-I-O-N, bupropion. This term means severe emotional disorder that impairs the mental function to the point that the individual can't participate in ADLs. Psychosis. That's the definition of psychosis. P-S-Y-C-H-O-S-I-S, psychosis. Psychoses is plural, so psychosis. Let's see. All right, before administering lithium, this is the most important lab value to check. Thank you. Sodium. All right. Let's look for this one. This herbal product is commonly used to treat anxiety and depression, but interacts with many serious meds like warfarin and digoxin, St. John's, and combining them with other antidepressants can lead to serotonin syndrome. What do you got, Bingo?
Oh, yeah, so-
Woo-hoo! All right, we're gonna keep going to play back out. Do you want your prize? All right. Next one out of it.
What was the answer to that one?
St. John's wort, right? Serotonin syndrome, highly protein bound interactions. All right, this class of antidepressant so we go to class and not to specific drug, has potential adverse effects of orthostatic hypotension, drowsiness, impotence, and 70 to 80% of people who overdose with it die before reaching the hospital since there's no antidote. No. Tricyclics. Remember tricyclic antidepressant, TCAs is the acronym for that. Tricyclics is probably what's on your card. Tricyclics. This drug is the oldest and most commonly used tricyclic antidepressant. And outside of depression, it's commonly used to treat insomnia and neuropathic pain. Amitriptyline. Good job. Learning our drugs out there. Big money. Love bingo. All right, this class of antidepressant blocks an enzyme involved in removing norepinephrine, serotonin, and dopamine from the brain. Thank you, Victoria, MAOI. Because MAO is what? An enzyme that breaks down neurotransmitters. And if we take an inhibitor, hey, we block the enzyme. MAOIs. We're playing now for blackout. So that means getting every box, for those of you who are not bingo literate, every box on your card. All right, bingo literate. This type of anxiety disorder is abbreviated GAD. Generalized anxiety disorder. Generalized anxiety disorder. That was pretty easy. All right, let's do this anti-anxiety drug. This anxiolytic drug is the shortest acting benzodiazepine.
Or alprazolam.
Yes, we use generics, alprazolam. Thank you, short acting. Three of them out there. All right, this type of psychosis disorder is characterized by positive symptoms, including hallucinations and delusions, as well as negative symptoms such as apathy, social withdrawal, flat affect, and reduced speech. You knew it. As soon as we started saying positive and negative symptoms, you're like, yeah, we beat that horse to death already. This class of antipsychotics has a better safety profile than traditional or first generation and includes drugs like clozapine, risperidone, olanzapine, quetiapine, cyprazidone, aripiprazole. Atypical antipsychotic, right? We like atypicals. This class of drug, according to the book, not according to me, according to the book, this class of drug is the most commonly prescribed anxiolytic.
This class.
This class of drug. Yep, benzodiazepines, according to the book. All right, we're playing blackout. Prize for a second bingo. Blackout means everything on your card. Every square is filled. All right, antidepressant therapy requires how long of drug therapy at adequate doses to be able to fully evaluate results? 6 weeks. Yep, that's the unfortunate truth. Yes. All right, this category of movement-based symptoms are a potential side effect of antipsychotic drugs, characterized by involuntary muscle symptoms similar to those of Parkinson's disease.
How you say that?
Extrapyramidal, muscle restlessness, and painful muscle spasms. It's extrapyramidal. Correct over there. All right, let's do this type of psychotherapeutic drug has side effects. This type. That's not a good word, but we'll go with it. This class of psychotherapeutic drugs has side effects of insulin resistance, weight gain, serum lipid level elevation, and metabolic syndrome, which can lead to drug-induced diabetes. What type of psychotherapeutic drugs have those potential adverse effects? What do I hear? It's going to be a group of drugs. SSRIs, antipsychotics, right?
Let's go through the list.
Keep going, you're going down your card to see which one sticks. Antipsychotics. All right, this anti-anxiety drug is non-sedating and non-habit forming and has been shown to relieve anxiety as well as benzos. But a potential uncommon adverse effect is paradoxical anxiety. Buspirone, yes. So know that that's the alternate to benzos.
What was the last one you said?
Buspirone, antipsychotic before that.
That's what it is. She's antipsychotic?
Yeah,
Oh.
it's what can fit on the card, all right? I'm limited by the number of characters. All right, this non-drug therapy should be used along with a patient's antidepressant drug therapy. Psychotherapy. Yes. That's a gimme. All right, this one.
You're so close.
So close. This category of mental disorder has 3 divisions that include anxiety disorders, psychoses. No, there are 3 divisions for mental disorders, which are anxiety disorders, psychoses, and one of the very first slides where we were breaking down the mental disorders into categories. We said there were anxiety disorders, psychoses, and affective disorders. Affective disorders. So that's the larger umbrella of groupings. Getting close, I can feel it.
7.
You more.
This class of antidepressants are first line and thought to act by inhibition of serotonin reuptake and possible effects on norepinephrine and dopamine. What's the first line as antidepressants that we generally start prescribing these days?
Is it the SSRI?
It is the SSRIs. Remember antidepressants, we talked about TCAs, MAOIs, and then we went to SSRIs, which are generally our first line therapy. All right, getting closer and closer. This SSRI, so it's a specific drug, is taken at bedtime due to its sedative properties, so it's sometimes used for this symptom of depression. It also tends to cause an increased appetite and is sometimes used for that symptom of depression as well.
What is it?
I thought it was.
Is it Halabi?
What'd you say? Mirtazapine, yes, it's mirtazapine, antidepressant, appetite stimulant, helps with sleep. Mirtazapine. Mirtazapine. All right, this is an antipsychotic. This antipsychotic is indicated for long-term treatment of psychosis and is useful for treatment of those with schizophrenia who were non-adherent with their drug regimen. It's contraindicated in Parkinson's and patients taking large amounts of CNS depressants, and it can be given oral, IM, or IV. Haloperidol. Yep, that's a whole lot of things for one drug, but yes, a lot of things to learn. All right, we're getting down to the wire. This category, specific drug, this category of drug is used to treat bipolar disorder. Mood stabilizer. Nobody's got blackout. Whew.
Oh, I'm so close.
16. All right, this. All right, everybody knows this one. Treatment of a benzodiazepine overdose is generally symptomatic and supportive, but this drug may be used to reverse the effects. Flumazenil. Everybody knows flumazenil. All right, get down to the end. Come on, randomize it. All right, this category of antipsychotics have improved efficacy in treating both positive and negative symptoms of schizophrenia. So which category of antipsychotic treats both positive and negative? Atypical, right? First generations were better with positive, atypicals are better with the, did we?
Yeah.
Well, maybe there's two. Oh, I have two atypicals on there. Oh, sorry. 31. That one just was, nobody got it then. The name of this adverse effect from a certain class of antidepressant is manifested by delirium, agitation, tachycardia, sweating, muscle spasms, muscle rigidity, hyperactive reflexes, and shivering. It can lead to hyperthermia, seizures, heart rhythm abnormalities, kidney failures, and DIC. What is this? The name of this adverse effect? Serotonin syndrome. So basically, I just gave you all of the symptoms of serotonin syndrome. Let's do. Get to the end. This anxiolytic drug. Anxiolytic drug is the longest acting benzo and is used in the management of alcohol withdrawal, reversal of status epilepticus, and pre-op sedation. Diazepam. Long acting. Blackout! Oh, no! All right, all of the rest of the questions and answers, I'll publish them in this week's module. You can review them. Thursday, chapter 17, and then